The ideal way to use this drug, or to use a FLT3 inhibitor, is to introduce it up front with induction therapy in a newly diagnosed FLT3-ITD AML patient. And the studies using what I would call not as effective FLT3 inhibitors still show a considerable amount of efficacy when you do this in increasing the remission rate. You still have to get that patient, what I think, to an allogeneic transplant, and then you give your FLT3 inhibitor after transplant. So I think the ideal way a drug like this would be used is 7 and 3 overlapping with the FLT3 inhibitor, get the patient in remission and keep them on the FLT3 inhibitor long enough to get them to an allogeneic transplant. I don't think you need a myeloablative transplant, just what we call a mini transplant will do. Introduce the immunotherapy, add the FLT3 inhibitor after transplant. And I think when we do this, and we are in active negotiations with cooperative groups to institute that kind of trial, I think we're going to see a quantum shift in the survival for this disease. We're not going to cure 100%, I can guarantee that, just with this approach, but we're going to finally make a substantial move upwards in the survival curves.